Hello, everyone. Welcome to this ISfTeH webinar on trustworthy medical AI, which starts with better data. This webinar is presented as part of a series that we're organizing together with our national member societies, national telemedicine and eHealth societies around the world. And we're very pleased to have with us today the Czech Society for Biomedical Engineering and Medical Informatics, represented here by Professor Lenka Locka, who will do the actual presentation today. For those of you who are not yet a member in the International Society for Telemedicine and eHealth, or who are not fully aware of who we are and what we do, let me just give you a few pointers and information as to the International Society for Telemedicine and eHealth, which is a global network of digital health stakeholders. It was started up and officially founded in the late 1990s. It's registered as a nonprofit in Switzerland. We also have a role as a non-state actor in official relations with WHO, and actually some of our board members and members are currently at the World Health Assembly in Geneva, attending the assembly, but also a number of side events. So those are things that we also work on with our members to provide access to such kinds of events. But in general, it's a networking organization trying to bring together experts and actors in the field of telemedicine and eHealth, digital health, to collaborate, to get to know each other, to make connections, and to move the use, the knowledge, and the implementation of digital health to move that forward. As mentioned, global network of national telemedicine, eHealth societies and associations, but also other institutions involved in education and research, companies, commercial companies providing the technologies, the platforms, the products, hardware, software, etc., needed to do telehealth, to implement digital health solutions, etc. We also have individual members, student members, nurse members, and they get together to network and create those ever important connections. We have a number of working groups on specific medical disciplines like telecardiology, teleaudiology, teleurology, etc., but also on more transversal topics such as healthcare disparities, digital transformation leadership, and others. That's where members can come together to collaborate on some of those things. We have a number of initiatives ongoing in education and training, also around accreditation of telehealth services. So that's the quality assurance, a student contest and award every year. And we're also looking into funding and investment opportunities in digital health technologies. This is today's webinar, and you will be able to find this recording back on our YouTube channel, where actually also the previous webinars in this series with our national members are available, as well as other sessions and webinars that we have been holding. This is our general contact information. And with that, I would like to hand over to Professor Lenka Locka to do her presentation today. If you have any questions or comments, feel free to post them in the chat window or in the Q&A window, and we'll be picking up on those after the presentation. Lenka, over to you.
Thank you, Frederick, very much for your wonderful introduction. Today, I would like to present to you, and I hope I will succeed to bring it to the whole. Yeah. So I hope you see my screen. But it's
still in. It's not yet in. Yeah, now it's in presentation.
Yeah. Okay. Maybe you can ask immediately at the beginning why me and why this topic. So first of all, I am very proud that I represent here the Czech Society for Biomedical Engineering and Medical Informatics, not only because we are for long years member of the International Society for Telemedicine and eHealth, but also because last year we celebrated 50 years anniversary of our society. And why this topic? You will see it during my presentation in the slides. What is the motivation? Currently, the technological development is so fast, and also we can see in medicine, e-health, and telemedicine that it's generating and storing, managing, and processing ever increasing volumes of data. We have more and more devices. The data which these devices can produce are very heterogeneous. They are multimodal, sometimes structured, sometimes unstructured, and sometimes noisy and incomplete because you can imagine easily in telemedicine that sometimes the connection is not functioning very well. Sometimes just pieces of data are lost. Sometimes when we do direct measurement on the patient that the sensors are not working properly or they lose contact with skin and so on. So we can really identify so many different examples of causes of these problems. And moreover, data in medicine have also specific features. It's not like the financial data showing us development of the rates of currencies or prices of good, but sometimes we have very small data sets. Small, I mean, we have hundreds, sometimes just a few thousand of patients. However, these data sets are usually described by a large number of symptoms. So it's not so easy then to use different methods for handling this data and for their evaluation. Usually simple statistics does not work so nicely. It can work on a large population data or epidemiologic studies. However, when we target some diagnosis, it does not work so easily. And moreover, we have also rare diseases, and these rare cases are quite a special story in medicine because usually when we collect data from a larger population, these rare cases, rare diagnoses seem to be some outliers. Simply, statistician would say it's noise or there are wrong data. However, when we go more closely to such data, we find out that there is something different, and this kind of data, these outliers cannot be ignored, and they must be taken into account because they show something special, and usually it's connected with the diagnosis. There are also new methods that can support our work, and sometimes it's very useful when we can integrate an expert or several experts in this knowledge discovery process. That means that it's not an automatic process, not automatic analysis, but sort of an interaction. We sometimes call it expert in the loop because the analysis is guided by the knowledge of these experts. And the scale of methods we have currently available is very broad and goes from the field of structural learning up to graph models using probabilistic mathematical apparatus or deep learning methods. Also, what is a great help is proper visualization of data, the whole processing process and the results, so that we can see in graphs, in some plots, how each step in the processing looks like and how far is it from the results. Of course, another point is the need also for increasing reliance on data-driven approaches in medicine. Why? As I said, the devices can generate really large data sets, and it's no more possible that people can check all this data manually. And of course, we can utilize these large volumes of data with an advantage for diagnostic and also treatment planning. When we have also long-term data from one patient, we can more easily develop a model of such a patient and to develop personalized medicine. So this is very frequently used also for better planning of pharmaceutical drugs and their use for special patients. Quite frequently now it's used in oncology, for example. It can be also used for drug discovery. So, and in all these cases, we face the problem of data quality, which is of critical importance for such applications because sometimes quite frequently, lives of people depend on proper medication. So we can say, okay, we have now this big data approach. We have real big data. So we can easily work with that. No, it's not so easy because the task is to extract valuable insights from large data sets. And only if we have high quality data on the input, we can receive high quality results on the output. It does not mention that if we have high volumes of data that we always get good quality results. No, we can see it currently with different already described examples of use of large language models, because when we just put wrong information on the input, the models learn quite stupid things and give us unreliable answers. And the same is with all these models. That means that we have to be very careful about various properties of the data, as we will see later on, like noise and bias. You see here a list of various consequences of use low quality data. That means that really the results are not reliable and are not correct. I hope I can go to the next page. Something got wrong. I'm sorry. I need to find the problem how to continue in my presentation because it got stuck in one moment. I have to start it once again.
Okay, that's fine.
Sorry
No
for that.
problem.
It
Don't
happens
worry.
sometimes. I was quite fine till the last moment. Yeah, now it goes further. Sorry for that.
No worries.
Yeah. As I mentioned, the data quality is really a big topic, and again, we can view the quality from different point of views, but the basic characteristics are completeness, that we really cover the given problem, that the data are consistent, accurate, they have the time aspect. That means that they are really up to date. If we follow also the longer period, so that we know in which time stamps we are moving, and also that the data were validated. Of course, the medicine is not an easy area, and the healthcare environments are quite complex. We as people are very heterogeneous. The heterogeneity is based on age, gender, ethnic origin, even a location where we are living, because the environment also is influencing our health state. And we have diverse sources of data. Even if we just, for example, take magnetic resonance imaging, we have different producers, we have different parameters of each device, starting usually from 1.5 Tesla up to 7 or 9 even. And if you compare the images of the same organ, you can see the differences between the devices. In that case, we have to ask, can we compare such data? How reliable will be the results? Concerning bias and noise, I would like to recommend two very interesting books which consider these aspects of data in different areas of our lives. And you can find their examples from finances, from medicine, from court trials, and so on. So it's if you plan some reading during summertime, it's very nice reading. Both books are written in a nice, understandable style for everybody, and they bring you also to areas where you wouldn't think about bias or noise in data, but surprisingly, it's almost in all our areas we work or live. So I already mentioned the issue and balance between quantity and quality. And we need to understand also the term of quality, or how we see quality of data. So therefore, I just picked up one of the definitions of quality, what we see behind it. And so it should also meet the product we have. That means our data analysis defined or anticipated needs. For example, usability, conformity to requirements, or user satisfaction. So in most of the cases in medicine, it's really the conformity to requirements to reach either the diagnosis as precise as possible, or to design a treatment plan, again, as best as possible. We can talk about information quality in data, because what we want to get from the data, we want to get information. And this information quality can be again described by several dimensions, like accuracy, completeness, consistency, validity. We saw it already in data. And then redundancy. Sometimes we need redundancy because we are always not so sure whether we always get all the data we need for final decision making. Therefore, it's sometimes good to have redundant resources. Readability, understandability. It's just for us as people to understand what's behind the data, what's behind the information that was aggregated from the data. Accessibility. That means that the information is accessible through different sources all the time and in all places. That means that we reach it usually via internet. That we can trust such information. That's again closely connected with validation and verification, both of the data and algorithms we use for the information derivation. Usefulness. Sometimes the information is completely useless, but it's somewhere in the data. So what we want to get is the useful information. So going to individual types of these aspects or attributes of data we want to avoid or minimize their effect. Again, what means noise? It's usually something that is brought to data either from the environment. It can be some artifacts in measurements. It can be electromagnetic noise if we use electric devices and so on. So there are so many sources of noise that we have to identify. And moreover, we have to understand the source of noise, because only then we are able to find such methods that can minimize impact of this noise, either by using mathematical approaches to either eliminate or at least reduce the noise. There, as I mentioned, there are different methods. It depends on the character of data. If we have just simple text or numerical data, we can check it even manually, of course. It's the basic way how to do it, using different data cleaning or normalization method. We can detect outliers, but as I said in the introduction, we have to remember that sometimes the outliers are significant. So it's good to detect them, but not to delete them. That are two different points. And then, of course, using signals, we can use standard mathematical approaches like Fourier transform, principal component analysis, and so on. Nowadays, there is a long list of different neural network types that can be also used for this data cleaning. And also in machine learning, we have different methods for noise reduction or noise elimination. You can again see some of these examples on the slide. Going to bias is even more difficult, because the bias can appear in different situations differently, different data sets, and again, depending on what we are looking for in data. And there are also groups of different types of bias that are having different causes. Typical bias is disbalance in groups of patients by gender, by age, and this appears quite frequently. Let us show at least few basic types of bias. We have even historic bias, which is caused by existing societal and technological issues. It is closely connected with the process, how the data was generated, what were the pre-trained models, and so on. So again, to fix this problem, we need to have the information which is here listed under the cause, so that we are well aware also how this bias was created. Representation bias is quite a frequent type of bias, because when we have a larger population and we do some sampling from this population, it might easily happen that the samples are not representing the whole diversity of population. They can easily miss some subgroups and other anomalies. So again, it depends how we define the hypothesis for data collection. If we say, okay, we would like to follow the age group between 40 and 50 years of female population for special diagnosis, that's a relatively narrow group, but it's not enough. We have to ask, okay, can we get data from the whole world to identify also different ethnic groups or also different environmental condition, or go we down and narrow it even to one continent, one country, population in the cities, rural population, and so on. So it's really quite a tough task to find out how to define this population sample to really avoid representation bias. Similarly, we can come to aggregation bias just coming from these subgroups where we have already the data, and then to come to a conclusion which is not really connected with the sample we had in these subgroups. So again, we have to find out how these observations are connected with what we want to have as a result. That means some special diagnosis, differences, for example, by gender or age. And again, to be very precise in finding or such data sets where we cover the population we defined at the beginning. Population bias. It's again quite frequent type of bias, and it's coming from the set we have available. And again, we have to say, okay, do we collect all the data from one country, from more countries? What will be all the parameters we want to follow? Because even if I say, okay, I would collect all the CTs from patients which go to hospitals in the Czech Republic. So the next question should be, which data about all these patients I need to reach reliable results for the defined tasks. So do I need the information about ethnicity, age, gender, lifestyle, whatever? Because sometimes for the given task, it's really connected with all these parameters. Another relatively frequent bias is sampling bias. If we have already subgroups and we use non-random sampling, so just by selection of the samples, we can create this kind of bias. We can also create bias in assessment of longitudinal data. Again, we need to have a consistent timeline when we use different diverse cohorts of patients. It's usually in some multicentric studies. So we need to have the same timeline and to check them at the same time points. Quite bad finding is when we find that important variables were left out of the model. And usually if we try to go to retrospective data, we find out that some data were not collected at all, which are needed for the correct decision making. So this is also something which must be considered very carefully immediately at the beginning when we start data collection. And then there are also biases that are somehow connected with the network. That means computer network, internet, where we sometimes also do the analysis connected with the behavior of the users. And again, it's something relatively special, and there can be defined many different attributes. And again, how we use them, it can be source of either good quality data or some bias. Measurement bias. Again, using measuring devices can bring on one side noise, but also sometimes even the bias, just how we use and measure specific features. It's something different than noise, because this process of measurement usually contributes to the error of measurement. And also we have to consider that each measuring device can have, just by its construction and the way of measurement, measuring error of the device. So that there are more components that can contribute finally to this bias. And sometimes it's necessary also to note not only type of the device, for example, ECG, or but also the proper type and the producer, because there might be some specific features just of the measurement output, and we usually know how to handle it, but we have to know what was the device. Yeah, and if we identified all these problems, so we have to ask the questions how to reduce bias, especially nowadays in machine learning models, but the same is for other type of models. We have to know how we can at least reduce the bias, or in the best way, how to eliminate it. And I don't have time, unfortunately, to go really into detail of each method, but there are two larger groups of methods which uh, differ in their approach, but they are either distributional methods or algorithmic methods, and they can not easily, but quite efficiently handle the bias, or find a way how to reduce bias by different approach to data. That means that in such groups of data where we don't have so many samples, we can do augmentation, we can do perturbation on the whole set of data, and so on. And the same with some other types of machine learning methods that go to this group of algorithmic methods. I also found a very interesting paper, and currently I'm sure there are many more because quite many authors tried to find out these biases in different data sets, and also to illustrate what kind of biases is also observable in recommendations of large language models. And you can see here that it was published last year. The authors evaluated altogether 9 large language models and analyzed 1.7 million outputs from 1,000 emergency department cases, and each case was presented in 32 variations. And what was the result? One which we already experienced, that fairness is not guaranteed in generative AI models, and that the treatment recommendations differ depending on whether the patient was, for example, rich or poor, younger or older. That means that there was already some bias in the models which were used for this decision making. So, in other words, we can't rely on these general large language models when we ask, especially about questions on medicine or medical problems. We need to have reliable models that undergo rigorous validation and are assessed also by experts. So these open models are not the right way how to use these algorithms in medicine, and that can be proved also on other types of models, not only language models. So this led us also to design of data collection procedure that can finally result in a good and reliable data set. These are the 10 critical steps in the data collection. And as I already mentioned, it's very important to define the study objectives and hypotheses at the beginning. Why? Because once we start a study, especially with patients, and we don't collect the proper data, all types of data we are able to collect in the study, then it's difficult to come back and I invite all the patients again and again to collect the rest of the data. And in the meantime, also some of the parameters of the patients, probably due to good treatment, can change so that we do not have relevant data. So the first step is very, very important. And usually when my students or PhDs asks what kind of data they should collect. So I always say, think about it and collect as much data as possible. That means also you think you don't need even the height and weight of the person. Measure it because you never know, you might need it for your study or for your analysis as additional parameters. Then, of course, we need to answer the question whether the study is more observational or experimental, because again, it defines some other steps we should follow. Also, the target population. How big the data set must be. Yeah, we can go to statistics and use power analysis to calculate the minimal data set. What will be the sampling strategy? Do we need to define either inclusion and or exclusion criteria? Again, it's connected with the objectives and hypotheses. Then all the variables and data elements we can measure, we have to describe precisely. In case of data that we really need to measure, we have to define the conditions of the measurements. Sometimes it's very important because some parameters of especially of humans change with temperature, humidity. So again, all these measurement conditions must be recorded because we need to compare the data. Also, it's good to design the metadata structure because it brings us additional information about the devices, about the environmental condition, and so on. In the middle, we have data collection protocols. Again, are some experiments, measurement experiments repeated? What is the interval between the measurements, for example, and so on and so on. So we have really a great potential in data collection, but it must be really defined step by step because it must be repeatable by another person just to verify the experiment. Again, in this point, what I usually recommend to do a small pilot test and test this data collection protocol on a small sample healthy people. It's not necessarily on patients, so that we see whether the design is well done, whether all these designed intervals, for example, are adequate to what we want to get. And now it comes to these questions of noise and bias. Of course, the ambition is to minimize the noise even before, so that we understand what might be the potential sources and how to avoid some of these sources and how to minimize the noise as such. That means which methods would be the best to remove the noise as much as possible. And the same is with bias. That means, again, it's connected also by a selection of the target population and the sampling, so that we really have to anticipate in advance potential bias and to minimize it by this proper selection. And last but not least, we have to ask the questions about the data privacy and ethics when we do the real experiments with human, and to check whether those items we designed are compliant with ethical and legal regulations in those countries where we collect the data. And when we got the data, it's great when we have already our data set. The question is how to store them securely and how to monitor it, not only the data set but also the analytical part of all the methods we are using, including control of different versions of the processing, different methods, and also doing backups properly. Again, it's sometimes not as it should be. That means that sometimes people say, "Oh, I don't have time. I will do the backup next week." Yeah. Sometimes it happens that finally after a week all the data are lost and we can start from the beginning. So backups is a must, and if we collect really precious data from not only from the academic point of view but also from the medical point of view, it's really necessary to do the backups as frequently as possible. That means at least once a day, depending on how much data we are able to collect in one day. But I strongly recommend to do that because it really saves a lot of time and energy. And last but not least, at the end, there is the quality control and also proper documentation of all the data we collected, because after some weeks we can easily forget what we did in which step, and if we have proper documentation we can easily refresh our memory and continue what we just stopped before. And quality control, again, the best way is to do the data quality control continuously during all the previous steps. That means immediately when we start to collect data, we should also check the quality so that we don't lose so much time when we finally come to the last point and check the quality of the whole data set and we find out that it's bad, that the data were distorted and so on. So it's better to do it continuously from the beginning. So what to say in the end? Data quality and discovering noise and bias are really critical consideration in medical data analysis, and it can bring us a lot of problems if we don't perform the data quality check continuously. And on the other side, if we do it very well, we have a high quality of medical data sets which are reliable and bring us also good material for medical analysis. for future, and also can help us in development of data models for different types of diagnosis, for generating the treatment plans and so on. So it's really necessary to be very careful and very strict about these individual steps to keep high quality. Thank you so much for your attention, and I'm looking forward to your questions.
Thank you very much, Lenka, for this presentation. It's clear that in AI and large language models, quantity is important, but it is nothing without quality data. And I think based on your expertise and research, you have given some ideas and suggestions, recommendations as to what people need to think about, what they need to look at, and in order to make sure that they do indeed have a good quality data set that can lead, obviously, to good AI models and good outcomes and recommendations. I would maybe immediately like to pick up on some of the questions that were put in the Q&A window. We have Carl Struttmann from our national member in Germany, the German Health Telematics Society, who was asking two things. He says, where do missing data come in? And then the other one is, how do you define fairness? It seems to make a lot of sense that treatment recommendations differ between young and old, etc. Do you also see the questions in the
Yes,
Q&A window?
yes,
Yeah. Are
I
those,
see.
yeah, do you have some feedback on that, or you need more clarity as to what he's referring to?
Well, for example, missing data. Simple example, I have let's say one bracelet with sensors, and then I have this how is it called, the band, polar band for
Yeah.
measuring ECG and breathing frequency. And suddenly I have just the data from the polar band, but no data from the bracelet about my what I can measure. They say that they can, yeah, I can have there the accelerometer, so that I measure my physical activity, number of steps. I can measure also the heart rate, and when it stops. So I have only this polar band with the ECG from which I can derive heart rate, and I have the breathing frequency. Then I have to ask, well, okay, am I fine with these two data sources, ECG and breathing, or do I need also the information at least about the physical activity? If I say no, because I knew the person has the mobile phone, so and with GPS, so I know that he went half a kilometer, for example. So missing data from the bracelet, okay, I can live with that, but it should be somewhere recorded in a comment or in this metadata that this data source just didn't work, so that we don't really try to get the data, dig it out somehow, or find it. Other missing data, it can be, for example, if some data is entered by the patient himself, herself, or by a nurse. For example, nowadays the diabetic patients still record their menu for then calculating the insulin dosing and so on. if the patient forgets to record what he wants to eat or what he was eating during the day, again, it's a source of missed data. The nurse can forget. It happened sometimes to record the given medication during the day. So there are really different sources and reasons why we have to handle this missing data. Defining fairness, it's more difficult. Yeah, fairness, again, it should be what I mentioned. You are right, Carl, that there might be different treatment recommendations for young and old people, and also for different patients with different diagnoses. Fairness should be in the sense that all patients, without considering especially their social status, should be given the same treatment. Of course, the treatment recommendations should be always adequate to the health state, to the diagnosis, and then I know that there were described cases that the health insurance companies just hesitated to pay for special treatments for people 80 plus and so on, like pacemaker or joint replacement and so on, or even some oncological treatment. It's really something which is also a big question in ethics. So here, really, if we speak technically, the treatment should be categorized by diagnosis, maybe by gender, because even there are gender-dependent diseases and so on, but not that the old person is just waiting for death. Yeah, it's exaggerated, but sometimes it's really considered like that, unfortunately. On the other side, the experience of the old employee is sometimes more valuable than the freshman who doesn't know anything. Yeah, so yeah, but it's more ethical question in this sense. So it's how we handle it technically.
Okay. And I think maybe because the next question in the Q&A, yeah, I think also sort of
Yeah.
refers, or you've addressed it at least partly already with what you were saying to the previous question around, factoring in social determinants of health, etc. And I know that certainly with some of these people, like with Carl, you're also interacting within the group of national member societies in the ISfTEH. Lloyd Williams is also one of our members. So there are definitely a lot of opportunities beyond this webinar to engage among yourselves and discuss this very important topic further. There was still a general question from Dr. Wosho in Nigeria around certifications in telemedicine and eHealth. This is something that, well, we're also working on with some of our partners to set up basic training courses or sessions that will be made available as of later this year. But obviously, we have other partners and members who are also offering either short courses, online training sessions, etc. But also a lot of our national member societies, universities, etc., have specific programs and curricula in telemedicine and eHealth. So again, feel free to look at those or to get in touch with us, and we can direct you further to some of the specific things that you're looking for. With that, actually, we've come to the end of this 1 hour webinar. So I would like to thank Professor Lenka Locka again very much for her contribution and the presentation. The session will be made available on the ISfTEH YouTube channel. If you have any further questions or want to go into more detail on some of these questions that were asked, feel free to reach out directly to Professor Locka or to us at the ISfTEH, and we'll be happy to address them, to forward them, etc. And just one final note, in this series of webinars that is being organized by our national member societies and which is coordinated by our national member representatives on the ISfTEH board. We will have a next session at the end of June. It's planned for June 26th, where actually Tunisia will be featured through the Tunisian Society for Telemedicine and eHealth. We'll have more details on that very soon, and we'll be sharing them through our various social media channels and website. So we look forward to welcoming you there once again. So thank you all for joining. Thank you, Lenka, for your presentation, and look forward to seeing you again soon.
Thank you very much. It was a great pleasure for me to be with you. Thank you.